Okay. Okay, can you, I can't see me now. I just see the board. I just see the first slide. Can you guys hear me?
Yes, we can hear you loud and clear.
Okay, how come I can't see myself? Oh yeah, there I am. Okay. All right. Hi, everybody. My name is Dr. Kate Tennant. I know everybody. Congratulations on your doctoral degrees and your first presentation for Scholarly Day. It's so good to see everybody. The people in the room there, I see Dr. Engel, probably Dr. Spence is there. Dr. Kozlina Paretic is there. I don't know who else. If you guys want to introduce yourselves, and then we'll get started. Can you hear me?
Yes.
Yeah. Okay.
And Dr. Marcy Radakovich is here too.
Oh, hi, Marcy. Okay, Dr. Radakovich. All right. Let me see. Is everyone, wait, I just want to see the participants. Okay, so we have Nicole. Okay, Nicole's in. Okay. Okay. And I see some people on the outside, and Chase, Nicole, CJ Huber, and Lena and Leslie. Okay.
Hey, do you see Corie? Wait.
No. Who's Corie? I mean, it's not, he's not on the, not,
Corie
they're not on
Scanlon, can you?
yeah, no.
Okay, you'll be moving Corie in. So.
Oh, well, okay.
Go ahead. So I'll
Well,
just
if you're
begin.
there, if they're in the room, it won't be on this.
No, they're virtual, but they're going to be moved from room to room.
Oh. Why, what happened with that?
Yeah, that's fine. We were in 116, now we're in 117. So I'll just begin, and I'm going to begin and introduce and Dr. Leslie Richards. I'm Dr. Diana Kozlina Paretic, and I'm chair of Leslie's project. Leslie is a graduate of St. Vincent College, and bachelor degree in chemistry, cosmetology chemistry. She's also a graduate of Allegheny Community College and Carlow College BSN program, as well as Carlow College MSN program. Leslie's been a registered nurse for 13 years and a nurse practitioner for 6 years. As a nurse, she's worked in the emergency room and the progressive care unit. As a nurse practitioner, her experience is in nephrology, family practice, and hospital medicine. She currently is working at UPMC and the lung transplant unit. Leslie? Welcome, Leslie, in her presentation.
Hi, everyone.
Hi, Leslie. Okay, honey.
Can you see this?
Not yet. You have to put your slides up, but not you. You like or share screen. Can you just put the slides up?
Look in here. Okay.
You might see half there. There you go. Okay.
Okay. Now she's okay.
Now just hit the first. Yeah, hit the first one.
Yep.
Good. Good job. Okay, we got it. Thank you.
All right. No problem. All right. I would like to thank my chair, Dr. Kozlina Paretic, for all of her help. I would also like to thank Dr. Zambodi for all of her assistance with the statistics. I'd also like to thank my preceptor, Dr. Danielle Weimer Tomlinson, for her assistance, and my community advisor, Jamie Stetchuk, Form D. So the World Health Organization defines polypharmacy as the routine use of 5 or more medications, which includes prescription, over-the-counter, and complementary medicines used by individuals. This is very prevalent in the geriatric population, or those individuals that are 65 years and older. Consequently, polypharmacy results in potentially inappropriate medicines. A potentially inappropriate medication is best defined as a medication that could lead to significant risk of an undesirable drug event and occurs as the result of the prescribing practices, such as continued therapy for longer than recommended according to prescribing guidelines. So when we look at the geriatric population, 66% of these individuals have 2 or more chronic diseases. And prescription drug spending is very costly, and the burden of taking multiple medications leads to greater healthcare cost. So for example, in 2020, prescription drug spending increased by 3% to $348 billion. Patients with chronic diseases like chronic kidney disease, dyslipidemia, cardiovascular disease, and COPD take a lot of medications for the management of these diseases, and these are also prescribed by many different specialists and specialties. So although specific disease guidelines do exist for chronic conditions like diabetes and hypertension, when we tend to follow these, this can lead to inappropriate medication use. So cardiovascular disease is a class of diseases that involves the heart and blood vessels and can refer to many numerous conditions like heart disease, myocardial infarction or a heart attack, stroke, heart failure, hypertension, rhythm disturbances like heart arrhythmias, and heart valve disorders. This is a major cause of morbidity and mortality, especially in the geriatric population. And patients with cardiovascular disease tend to experience very frequent hospitalizations secondary to the sequelae of their disease and other disease exacerbations. So evidence-based practice for the treatment of cardiovascular disease includes a combination of many different medicines to treat these associated conditions. So when we run into this problem, these patients tend to have more medicines on board than what we like sometimes. So screening tools for potentially inappropriate medicines like the STOP criteria are available, but not often utilized. So furthermore, healthcare providers need to implement ways to recognize and decrease potentially inappropriate medications after a hospital admission. So for this project, the tool that I am using, it's called the STOP criteria. It's an acronym and it stands for Screening Tool of Older Persons Potentially Inappropriate Prescriptions. This is a two-part tool. So the first part is the START criteria, which is a screening tool to alert doctors to the right treatments. And this consists of evidence-based indicators for prescribing omissions or medications that the patient should be prescribed. And then the STOP criteria focuses on the medications that the patient should not be taken, or also known as potentially inappropriate medications or prescriptions. This is a valid and reliable tool, and it's organized by physiological system. The purpose of this tool is to improve medication appropriateness and prevent adverse drug events. It was originally published in 2008 as version 1, and then expanded into 2014 to reflect up-to-date evidence-based guidelines. It can be applied at any time during a patient visit or even in the hospital to improve medication appropriateness. Studies have been shown that it identifies potentially inappropriate medication prevalence better when compared to the Beers criteria. So the PICO for this scholarly project is in primary care post-hospital discharge geriatric patients with a diagnosis of cardiovascular disease. What is the effect of implementing the STOP criteria at the 1 week post-hospital discharge to identify potentially inappropriate medications and evaluate patient outcomes that include hospital readmission, emergency room or convenient care visits, and unscheduled office visits? The study aims for this project are as follows. We're going to evaluate patient outcomes that include 60-day hospital readmission, emergency room visits, or unplanned primary care provider office visits, evaluate the effectiveness of implementing the STOP criteria at the 1 week post-hospital discharge appointment, and also to determine if demographic, disease comorbidities, and specific new factors like new medications and new medical consultations influence patient outcomes. The theoretical framework for the scholarly project is Lewin's change theory. Kurt Lewin is considered the father of social psychology, and he theorized a 3-stage model of change. We know that healthcare is ever-changing and requires providers to address complex problems and implement new practices and processes. So for my scholarly project, the unfreeze portion is creating problem awareness. So this means bringing a formal screening tool into place. The change would be action planning or implementing the STOP criteria at the 1 week discharge visit. And then the refreeze would be stability and evaluation, and that's evaluating the outcomes of hospital readmissions, emergency room visits, and unplanned primary care visits. Topics that have been published for this is as follows. The first one being determinants of potentially inappropriate medicines. A retrospective cross-sectional study included 13,221 people. And this was performed to look at the different variables that influence potentially inappropriate medicines. So it was found that those individuals of increased age, especially the female gender, and patients taking 5 to 9 medications and that have chronic comorbidities were more likely to have inappropriate medications. When reviewing the literature regarding potentially inappropriate medications in cardiovascular disease, this particular study included 239 people with the diagnosis of cardiovascular disease. And out of those 239, 221 were found to have an inappropriate medication for stop criteria. We also looked at the evaluation of different screening tools. So this particular study aimed to determine the prevalence of potentially inappropriate medication according to the Beers criteria, the stop criteria, the FORTA criteria, and the medication appropriateness index. There were 420 patients included in this, and the medication list of each patient was reviewed according to all the screening tools. The stop criteria was found to have the highest sensitivity to reflect potentially inappropriate prescribing. Two other topics reviewed were potentially inappropriate medications and hospital readmissions. This particular study was a cross-sectional observational study, and it was reported that potentially inappropriate medications are directly related to hospital readmissions and can be preventable. And then finally, post-discharge follow-up appointment studies were reviewed. And this study showed the importance of medication reconciliation and why we need to do it, because this reflects the changes to medications during an admission to reduce discrepancies. This was a retrospective study and involved 50 patients. Data was collected using the SOC criteria and the electronic records for a chart review. Permission was obtained from the IRPs of these facilities. So inclusion and exclusion criteria were as follows. The reason this population was chosen was because of the incidence of cardiovascular disease. And as a person ages, they tend to develop cardiovascular disease. And additionally, this specific population tends to experience frequent hospital admissions. So that needed to be included in this. And also patients needed to have a 1-week post-hospital discharge follow-up visit. The exclusion criteria were those that had a left ventricular dysfunction with an ejection fraction less than 40%, and those individuals that do not resuscitate or admitted to hospice. So for my data analysis, I looked at potentially inappropriate medications related to demographics, disease comorbidity, and medical consults. Potentially inappropriate it was found that they are prevalent among both genders, female and male, although there was an equal sample of male to female in this study. Relationship between potentially inappropriate medication and disease comorbidities. All patients had to have the diagnosis of cardiovascular disease, but the other disease comorbidities were composed of diabetes, chronic obstructive pulmonary disease, dyslipidemia, and chronic kidney disease. The data demonstrated that 8 individuals had 1 to 2 disease comorbidities with 1 potentially inappropriate medicine. 18 individuals had 3 disease comorbidities with 2 potentially inappropriate medications, and 24 individuals were found to have 4 or more disease comorbidities with 3 to 4 potentially inappropriate medicines. Relationship between potentially inappropriate medications and medical consults. There was a relationship between this. 17 patients had 0 to 1 medical specialty consults with 1 to 2 potentially inappropriate medications. 21 patients had 2 medical consults with 2 to 3 potentially inappropriate medications, and 12 patients had 3 to 4 medical consults with 2 to 4 potentially inappropriate medicines. The data analysis for the relationship between the number of potentially inappropriate medications and new medications at discharge. After reviewing the scatter plot, most of the patients were prescribed 10 to 15 medications with an average of 13. The number of medications meeting stop criteria was 2 to 3. And finally, looking at the potentially inappropriate medications and hospital readmissions, emergency room visits, and unplanned office visits, 14 patients experienced a hospital readmission within 60 days of discharge. This data showed that the potentially inappropriate medicines were predictive of the occurrence of a hospital readmission. There was no statistical significance for returning to the emergency room or unplanned primary care provider visits. So overall, the study did demonstrate that when the stop criteria is applied, potentially inappropriate medications are prevalent at the time of discharge, and the incidence increases for each medication prescribed. Additionally, the number of chronic comorbid conditions was associated with a higher risk for PIM use. The correlation between the number of chronic diseases and the number of prescribed drugs is expected. However, potentially inappropriate medications increase with they do increase with the number of chronic diseases. Medical consults during the hospital admission are also associated with increased potentially medication use. And the more providers on a patient's case increases the likelihood that a potentially inappropriate medication will be prescribed. Limitations to the study were as follows. The sample size was only 50 patients, which is still a good sample size because literature suggests that anything over 30 does give good results. However, the study was performed at only one primary care office with multiple providers, and these providers all practice differently, so that could definitely influence. The stop criteria was used for this project without the start criteria, although they are independent of one another. And then the population, this was limited to those only with cardiovascular disease. And future implications for nursing. We do need to start thinking about implementing a screening tool to identify potentially inappropriate medications. Additionally, it would be important to incorporate a multidisciplinary team like a physician, a pharmacist, an advanced practice registered nurse to help identify those patient demographics that are associated with potentially inappropriate medicines in the primary care setting. We have these multidisciplinary teams in the hospital, but often not in the office settings. And then, of course, to continue with further studies to assess screening tools that may be more efficient for the provider and identify other populations that are at risk for potentially inappropriate medications.
Okay. Good job, Leslie. Very good. Does anybody have any questions, please? We can't see the gallery, Maria. I don't know if that's just because they're in the classroom. Can you see us, Leslie?
We can see you.
No, I can't see you.
When you're speaking, then your screen will come up on the first slide.
I'll just stop sharing. You see right there.
Yeah.
Yes.
Yeah.
In the gallery view.
Yeah, wait.
Yeah, there.
I can see you, Dr. Tennant, but I can't see anyone else.
Yeah, me too. I can only see you.
I can
Well-
see everybody. I put in the gallery option view.
Okay, good. Thank you. I tried, but oh, good job. I see it. I see it. Okay, there you go. Everybody see everybody? Hit gallery on your computer device. Now I can see everybody. All right. Great job. Great job,
Thank you.
Leslie.
Are there any questions?
Kate, can you hear us?
Yes,
Okay, good.
yes. I have to admit, Leslie talks faster than me, so that's an award right there. I thought it was good. I thought it was good. 50 people, you're right. Oh, lordy, 13 medications. That's a lot. That's a lot.
It is. And Anne has a question in the room.
Go ahead, Dr.
I
Smith.
don't have a question. I just have a comment that, with all those multiple providers, I think it's one thing that we've been trying to do for
We lost the audio.
And so I think that your project does indicate that we need care team, like you
Yeah.
suggested, or some kind of coordinator, and to somehow get medication reconciliation down. We just don't have it down
Right.
at all. And it makes sense, the more providers you have, the more medication you ask for with the funding.
Yeah, so at my hospital, we do have a Form D that when a patient comes into the emergency room upon admission, they are supposed to look at their medicines and they are supposed to reconcile them and go over with them. It does make it difficult though when you're on two different EHR systems.
Yeah.
So you have to flip flop between the two.
Yeah.
And if something's incorrect in one and then, there's a discrepancy in the other, it makes it difficult. But it is true. We do need more people to look at these medicines.
We did that at children. We had a whole system, medication reconciliation, but it was too clunky. The system was too clunky.
Yeah.
We couldn't really figure it out. That's all.
Okay.
So I
Hey, anybody else
Dr. Engel does?
Can I,
has a question?
one thing
Oh.
is, you said the start and stop were supposed to go together, but I think you got good results with this stuff, because you don't know who's gonna go into the hospital or not into the hospital, so using the start might not be effective for every patient. So
Right.
I think doing this stuff was a good thing.
Mhm.
And the other thing, just one suggestion for the DNP scholarly presentations, those diagrams in your slides where you talked about, there was 3 slides
Mhm.
where you talked about the results and you said the number of participants, put that in a table instead. Take
Oh.
those diagrams out and put that in a table so that people can look, how many patients and what were the outcomes. It would just be easy to read,
Okay,
and that's all.
okay.
That was really good, Leslie. You did a great job.
Thank you.
Good job. Chase, are you ready to go next? Could you go next?
Yeah, absolutely.
Okay. All right, while you're getting your slides up, I will introduce Chase. However, unless somebody else, is it Ann or who was your chair, Chase?
It's Dr. Spence.
Oh, okay. Dr. Spence, do you want to, I have a little bio, but I didn't know we were, I just got these at the last minute because I didn't know how many people we were going to have look, in this session. Do you want me to go ahead and say it, Ann? Okay, I will. All right. This is Chase Imbriaco. He started his career in 2014 as an LPN, where he quickly found his passion for nursing. In 2017, Chase graduated from the Community College of Allegheny with his associate degree and quickly started his journey with Carlow when he received his BSN and then MSN in 2021. Presently, Chase works at New York Presbyterian Columbia. I did not know that, in New York, where he's a heart transplant coordinator. He focuses his quality efforts on patient education. Recently, he was named the project manager of the Heart Failure Black Health Initiative and was accepted to the NATCO Emerging Leaders Program. Good for you, Chase. He looks forward to continue his career with heart transplant and hopes to continue to be a leader in the nursing and transplant community. Here is Chase Imbriaco. Am I saying it right? Sorry.
Yeah, no, you did great. Imbriaco. That's
Thank you. Great. Go ahead.
Thank you, Dr. Tennant. Thank you, everybody, for attending. So today I'm going to present to you my ongoing scholarly project here, where we're looking at the implementation of nurse-driven transplant readiness education in waitlisted transplant candidates. Maybe. There we go. So the problem statement: patients undergoing advanced therapies at times may retain 50% of the information from the transplant coordinators at the time of their initial consent. A period of time may have lapsed from the time of their initial active waitlisting to transplant admission. So to provide a little bit of background, I'm at a high volume transplant center in New York City. We currently are the highest volume on the East Coast, with last year coming in at 79 adult heart transplants, with wait times from anywhere from 7 days from the time of activation on the UNOS waitlist up to 6 years. So educational levels vary, and we have seen that as the transplant coordinators through our own experience with the patient and the different levels of readiness. We refer to it as transplant readiness that each patient goes into the transplant with. This project aim, so the aim of the Quality Improvement Project is to determine the efficacy of a standardized nurse-driven transplant education in waitlisted transplant candidates. During my literature review, there is a large gap in the literature with transplant education in general, specifically heart. There is some more information about kidney transplant because of how substantially longer kidney transplants have been performed as opposed to heart, but there is not a lot of information based on transplant education. The majority of the information says that transplant education is given by the provider during the follow-ups, but no real formal education process has been studied or outlined that I was able to find. So we'll take a look at the background, or a little bit of this educational outline that we created. So this was created in alongside our PharmD, our post-transplant nursing or nurse practitioners, as well as our advanced heart failure nurse practitioners, and then my 6 co-coordinators. So we're looking at the history of the transplant waitlist. We're looking at the heart transplant statuses, which range from 1 to 7, maintaining health maintenance while on the waitlist, patient responsibilities while on the wait list, what to do the day of the call, which is referred to as the call of when you get called in to get a heart. We have that heart organ offer for the patient. We have donor selection, known risk factors, and what that means in relation to donors and what that means for the patient moving forward. We take a brief overview, look at the surgical procedure, the post-transplant stay, the medication teaching, infection and rejection prevention. We'll give a brief time for question and answers, and then we will go ahead and provide contact information. So this is in the form of a 24-minute narrated PowerPoint presentation. We felt that it was important to make it a multimedia, multimodal education. That way we could appeal to different learning styles, something that patients, could pause in the future if they wanted, when it, became available, or we could replay, something that they could read, but if they're auditory listeners as well, would have that. To go ahead and just kind of give a little bit of the patient experience, I have about 90 seconds of the presentation that I'm going to go ahead and play for you guys on the next couple of slides, just so you can, like I said, get to see the patient experience of what they're about to be going through. Hello, and thank you for joining today to review the New York Presbyterian Cardiac Transplant Readiness Education. In preparation for transplant, today we will review topics such as the history of the transplant waitlist, how to maintain your status as a candidate on the waitlist, the transplant surgery, and life with your new transplant. At the end of today's education, you'll have the opportunity to discuss any additional questions or concerns you may have with one of our cardiac transplant coordinators. Now let's begin. Let's start with a brief history. The Organ Procurement and Transplantation Network, as well as the Scientific Registry of Transplant Recipients. The United Network for Organ Sharing, often referred to as UNOS, coordinates the nation's organ transplant system. As you can see on this map, the nation is broken up into 11 regions. Represented in pink, you can see that New York State is in Region 9. So there is a brief little snip of what the cardiac transplant readiness education is going to look like. It is also has closed captioning on it, so they are able to read as well. However, I found that if I am presenting with closed captioning, it is going to put all of my words into closed captioning, so I had to turn it off for this presentation. But so there's several different learning styles that we're trying to appeal to. Now, the design of the quality improvement project is a pre-post intervention. So in addition to a promised self-efficacy scale, which we'll go over in a minute, we're going to first send out this transplant knowledge questionnaire. This was developed by the transplant coordinators as well as the PharmD for our transplant service line. And so we wanted to go ahead and just get a general idea both pre and post intervention as to what the patient's baseline knowledge was. So we have questions such as, on average, how long can I be expected to be admitted to the hospital after transplant? One of the main complications after transplant is, all the way down to after I leave the hospital, I will need to come in for frequent heart biopsies and doctor's appointments for the first X number of months. This also aligns with the written education that I redid for my master's capstone. So they are given this information prior to this session. It is just in a written book that is very cumbersome. And so they do have access to this information. So it's really going to be telling as well as if they've gone through the educational material on their own. We will then also go ahead and send them the PROMIS self-efficacy scale or patient-reported outcome measurement information system. So this was developed by the NIH, and this can be used in a couple of different ways. And I encourage all of my colleagues here to take a look because they have a variety of surveys that they've developed. And so what we're going to look at is general self-efficacy first. Let's go ahead and see just at a baseline, what is a patient's self-efficacy? So we answer questions such as, I can manage to solve difficult problems if I try hard enough. And then we kind of rate our confidence from 1 to 5. And then similarly, we go down to, asking things such as, I can solve most problems if I try hard enough. And what is nice about the scale, and for, Dr. Zamboni, is that it goes ahead and gives you a score, which then you can take that raw score and, convert it into a T-score through the scoring guide. So it will kind of give us a baseline. And then we're also going to look at something a little bit more specific to chronic conditions. And so we thought medication management and treatment is where we wanted to focus, because a large part of post-transplant education is medication compliance with your three main anti-rejection medications. And we really harp on that. And so we want to know, I can follow directions when my doctor changes my medications. What is their confidence level on this? Because we will frequently titrate up or down tacro levels by 0.5 milligrams at a time. So it does require a little bit of thought to go ahead and do that. We're also going to look at, I can take my medications where there's a change in my usual day. I can manage my medications without help, and I can list my medications, including the doses and schedule. All things that we already want our patients to be able to do, and we ask of them prior to discharge, but just kind of standardizing it and once again getting the results to see. So we're going to do this pre and post intervention. So this is the proposed project flow, which is currently under review with the Columbia University IRB. So we will have identified active waitlisted patients, statuses 3 through 6, who will be asked to participate in a transplant readiness education and survey. Our patient navigators are then going to schedule a video visit with one of the transplant coordinators. We will send a secured survey through our Qualtrics system, or a secured link through our Qualtrics system, which will take them to the pre-intervention promise surveys and make sure they're received and completed, as well as the pre-intervention transplant knowledge survey. We will then go ahead and conduct the transplant readiness education through the recorded PowerPoint presentation over a video visit with one of our transplant coordinators. Then we will go ahead and send out the post-intervention surveys, and they'll have about 7 days to complete and return. Additional demographics that we're looking to collect. So we're looking to see, really where should we target our efforts with our education? Because at this point, we simply do not know. And there's not much literature out there to tell us where we should be targeting our transplant education. So we're going to be looking at age, gender, race, status. So this is status 3, 4, 5, and status 6 on the transplant wait list. We're also going to be looking at length of time on the wait list. So we will have an exact number of days where we will record that number of days based off of the day that they have their transplant readiness, to see if we can see if patients who wait longer on the wait list have, more education, more self-efficacy because they've had longer to follow up in our heart transplant and advance heart failure clinic. Or is it the opposite, that initial education session with them was 3-4 years ago, and they simply, have not had enough follow-up. A quick timeline here. So as you'll see, we're around this April 11th mark where we've made the second submission to the Columbia IRB. As I said, it's under review with a hopeful projection to submission to the Carlow IRB May 16th with our data collection of from June 6th through August 14th. So projected outcomes, and what does this do for our program? What does this do for our patients? So it provides a better profile of waitlist patients in terms of understanding and identifying patients on the waitlist who require additional educational support. We hope that to implement this at routine intervals and continue to track and monitor, going forward. So not just for the DNP project, but to implement this in a series of educational modules and a standardized practice for our program. We help maintain patients in an up-to-date fashion as time lapses. We anticipate, once again, this will be implemented at various intervals as patients are waiting. And target which part of future educational series needs more focus. This is the point of the knowledge-based questions, and as well as the medication management questions through the PROMIS self-efficacy of chronic disease medication and treatment survey. Really looking to see, maybe we don't need to focus on medications. Maybe we need to focus on reporting of symptoms, which is another, survey that we're able to use through NIH. Or, maybe we need to focus less on pre-transplant or post-transplant education and focus more on pre-transplant and the health maintenance aspect. So we're really trying to target where we need to really focus our efforts as a service line for our patients. And that concludes my presentation. If anybody has any questions, comments, concerns. I know it's weird because I'm about to start collecting my data, but happy to answer anything that I can.
Can you hear me?
Yeah.
Could you talk a little bit about the theory that you're using for your project?
Yeah, so we're going to use the Bandura self-efficacy theory, hoping that by providing educational resources for the patients, that we will then go ahead and see them taking the initiative to improve their self-efficacy and their self-management. Some of the literature out there is that you actually have to provide the resources, and education is a great resource to provide a patient to improve self-efficacy. And there are some different services out there, such as not much in cardiac surgery, but there are some outpatients, such as like outpatient GI surgeries or outpatient OBGYN procedures, who are doing this education prior to the procedure, just to go ahead and improve that self-efficacy, improve their confidence and going into the procedure, as opposed to, loading them up with education as soon as you're done with the procedure and then shipping them out the door.
Okay, thank you.
Hey Chase, I have two questions.
Yes.
That was good. Good job. Good job on that. And it seems like an interesting study. You're comparing pre and post, and your intervention is the video education module that you're creating.
Correct.
Or that you created. Okay, so right now, what is the education that they get? It's only when they're initially waitlisted?
Correct. So right now they're getting a 60-minute education session with a transplant coordinator at the time of consent. And then they receive no additional formal education until post-transplant.
And so the reason why, what is the background and significance that you're doing this? Are you noticing that there are lots of hospital readmissions or medication mistakes, or why is it important to do this?
Yeah, so unfortunately, it's hard to track with hospital readmissions, because when we look at readmissions, transplant patients are frequently readmitted during that first index, that first year after their index admission, for multifactorial reasons. Sometimes they come in with pericardial effusions, but then we also see that their TACRO levels are significantly low. So it's hard, and they're rejecting. And so it's kind of hard to determine that that was education based, because we originally had looked at that. But what we're finding is that when we're asking and we're following up with our patients, they really, from a coordinator perspective, do not know much about transplant. They're unable to, answer basic questions that we go over at the time of the initial consent, such as what is the hospital length of stay, or what are anti-rejection medications. We're frequently asked, oh, I don't have to be on those for the rest of my life. And so we're really kind of looking at as that our patients just, honestly aren't prepared going into the surgery, not nearly as prepared as they should be.
So it would be really cool if you took your literature review and you associated it with some data. Like, patients don't know what's going on, and this is the result. This is how much it's costing us. This is resulting in readmissions. Like, if you took some internal data and made this kind of data driven and included everything that you just said, like anecdotally, you are reporting that they have lack of knowledge, but what is happening as the outcome that is demonstrating lack of knowledge? Because if the hospital is going to invest time and money in implementing something new for a patient, it needs to be cost effective. And if it's going to use resources, then they need to know that the resources, you know what I mean? Like, even if it's limited resources with your video, they still need to know that there's a reason to do it. So I would suggest adding those components in your literature review if you have, if you can find that information. Otherwise, I think your project's really cool. I just need to know the reason for it. If you're coming to me for $150 million, I'm gonna say, okay, you gotta tell me why. Besides that you think that you should, because I believe what you're saying and I know that it happens, but that doesn't mean anything to the end pocketbook, right? So if you could show us that, that would be very helpful.
Yeah, I'll definitely continue to look through, some of the data, because we have attempted to look at it. And at first, the original plan was to look at hospital readmissions because, after that index admission, it's just unfortunately that when we were going ahead and we were doing the chart review, it wasn't simply patient didn't take their medications or, it was very, broad. Pleural effusion came in with rejection, VTAC, all things low TAC-RO level. So we have thought, on the background, thinking about where we can take this data forward, moving forward, is taking these initial 50 people that we've identified and maybe trying to trend their TAC-RO levels over the course of a year, kind of going ahead and doing a retrospective to really prove, and see if we can see anything in the data and the numbers that this education really did improve TAC-RO compliance.
Yeah.
Chase, I wonder if you could look, since your question, that one section is about medication, if you can look retrospectively, just at maybe, at the same time last year, maybe, and see how many patients saw or came in whose TAC-RO levels were low. And maybe that would at least give you something to talk about in relationship to what you're teaching and collecting at the end.
Yeah, look at some retrospective data.
Yeah, that I definitely could pull the last, I definitely could pull in data on the patients that were admitted over the, the previous year, and then take a look at their admission and see what their TAC-RO level was, and if it was sub or super therapeutic. That I could easily do.
That's probably a good idea. Or there might even be another data point that you could look at. We understand. I know you tried to find readmissions and the reason for them and all that kind of thing, and it was really hard. But maybe you could take a couple of data points like TAC-RO levels and maybe just one other thing and look at a couple, however many patients you can find.
Yeah.
So that you could track those things.
No, I think it's a good recommendation.
Chase, are you the primary investigator?
So we're not sure yet. I'm listed as the primary investigator, but it has to go through the IRB. And if they are going to make it, if they deem it quality improvement, then I can be the primary investigator. If not, it's going to have to be my medical director.
That's fine.
Did you do?
That's fine.
Did you do a needs assessment? Did your team do a needs assessment?
I'm chiming in.
Yeah, we need to get to, I think Lena's up next.
Yeah.
We need to go to the.
Yes.
Hey, you're there, but we don't want to be getting home at midnight.
Well, you guys added the people. We
Good
had
job, Chase. Good job.
Thank you,
Lena,
everybody.
are
I
you
appreciate
ready?
it.
Thank you, Jane.
Okay, all right, I got Alina. All right, Alina is, who's your chair? I'm sorry. I don't have it. Sorry, go ahead.
Dr. Spence does.
Okay, Dr. Spence, you want to introduce her because I did not get her bio at the last minute.
I have it.
Okay, great, thank you. Sorry about that.
So, can you hear me?
Mm-hmm.
Yeah, okay. So Lena has, she earned her BSN and MSN at Carlow and now her DNP. So she is a lifelong Carlow student. She is currently the unit director at UPMC McKeesport, and she is learning all about leadership there. She has 2 daughters, a spoiled dog, and she also writes fiction novels. So there's one out if anybody would like to read it. It's called The Bite Shift. The Shift Bite, The Bite Shift.
You're right, bite shift.
Thought I'd put a little plug in for you. So Lena, go ahead.
Thank you, everybody. Thank you and good evening. I'm just going to take about 15 minutes to talk to you about my scholarly work, and I will give you time to ask any questions. But I thank you for being here this evening. I know it's a long night, but I do really appreciate it. Whoop. I'd like to thank Dr. Spence. I've been with her bachelor's, master's, and now doctorate. It's been my honor. Also, Dr. Beth Zamboni. I don't know what I would have done without her, as well as my DNP preceptors and my experts, Dr. Brandy Hirschberger, Dr. Frank Ricci, and Dr. Paula Thomas. So when I first started this journey, someone said to me, pick something you are passionate about because you're going to talk about it a lot. And I looked around myself and I said, I am passionate about turning the tide of nursing turnover and the nursing shortage and really protecting the future of nursing. I saw specifically around me a very high rate of turnover in frontline managers. I was at a large Western Pennsylvania home care agency. There was an anonymous survey that was sent out, and these managers were saying that they were experiencing very high levels of stress. From the summer of 2019 to the summer of 2020, 20% of those managers turned over. And when you look at something like management, you know, the numbers are smaller than bedside. So the loss of each manager is a little harder of a hit on the company. I looked at a recent national survey, which showed that 72% of frontline managers expect to leave their position soon. In this particular agency, they lost 20%, like I said. Half of those left in the first 6 months. The rest were within a year of their start date. And the evidence shows that when a frontline manager leaves, the staff that they were leading are at a very high risk of also leaving. So that is only going to negatively impact our nursing shortage and our turnover rates and people who are leaving the profession. So my purpose was to find an intervention that would decrease the stress and burnout of these frontline managers, to decrease their turnover rates, to positively impact the current trends and future nursing shortages. I asked myself, if I created a relaxation room with aromatherapy and music therapy versus the current practice, would I decrease the stress and burnout of these home care frontline managers over the 12 weeks of the study? I was inspired by Dorothea Orum's theory of self-care deficit. She theorized that the key to optimal health is balance, and that is a balance between work and rest, a balance between interacting with others and time alone. And she said, when this balance is not present, that's when you have dis-ease, or when your health is not at the state that it should be, and that's when intervention must occur. She actually recommends in that theory that we provide an environment where these individuals feel supported and health promotion is evident. I looked at the literature, and I will say it was difficult to find a lot of literature about managers. There's a lot of literature about how do we decrease the burnout of our patient care staff. Obviously, there's a huge focus right now on the patient care staff. However, this middle manager level, I think, doesn't really get the focus it deserves. I found out that occupational stress does increase burnout. It decreases productivity, engagement. It makes people not happy at work, and it leads to higher rates of call-offs and illnesses, which of course is going to exacerbate this issue we're already facing. And then we're going to find that we don't have the people we need to take care of our patients. Burnout causes people to be anxious, they don't sleep, they turn over, they have poor care or give poor care, and that's not what we want to see in our patient care staff. Home care services specifically, since that's what I was looking at, they prevent unnecessary hospital admissions for patients, and they also increase their quality of life and decrease poor patient outcomes. And when we're looking at things like utilization of hospital beds, we know that patient care staff right now is a limited resource, and so are those precious hospital beds. So if we can decrease people going to the hospital when they don't need to, we can protect those resources and protect our patients. I found in my research that the frontline manager in home care is responsible for many things, some of them being staff oversight, supporting their staff safety, education, mentoring. Finding a way to decrease the stress of this role can result in less turnover of those managers and therefore increase the opportunities for a patient care staff to feel supported and safe and mentored. And that's why I wanted to focus on nurse managers, because they are so integral to the success of the healthcare continuum. The evidence shows that when frontline managers leave their position, the intentions for their staff to stay will then decrease because they feel less stable, they feel less supported. Then their productivity decreases, they're less engaged. And then unfortunately, the managers who are left behind now have to increase the amount of work that they have to do to cover the responsibilities left behind. When these managers leave, the continuity of care for the patient is sacrificed and outcomes for the patients are negatively affected. And by decreasing the stress and burnout of these home care managers, we can give these patients higher quality of care, improved continuity of care, positive outcomes, while saving money for the healthcare organization by decreasing not just turnover, but those unnecessary hospital admissions. The literature showed me that music therapy has a positive impact on people who routinely feel these high levels of stress and a risk for burnout. And reviewing many studies showed me that the best things that I could do for these nurse managers were to have them listen to music no less than 20 minutes at a minimum of 3 times a week. I also discovered through my research that inhalation of lavender oil, when comparing to any other kind of oil or no oil at all, does decrease the stress levels of the people who are inhaling it. And the recommendation said to combine the aromatherapy with music in a quiet room, which is what I did do. And some of the studies showed me that just the opportunity to walk away from the workplace and enter the room itself would decrease stress and the risk for burnout for these nurse managers. The rationale for the study, as I've said, is that I want to look at how can I stop these nurse managers from turning over, have them more satisfied at work, more engaged, feel more supported, so they can then do that for our patient care staff. So our patient care staff can then give our patients great quality care. Unfortunately, when these managers turn over, it's only making that nursing crisis worse. The literature shows that I will decrease stress and burnout and decrease the risk of the manager turnover, and then positively impact the patient care staff left behind, as well as the patients they're caring for. So I combined music therapy, inhalation of that lavender oil, and time in a relaxing room all together to try and positively impact the stress and burnout levels of these nurse managers. And I did name the room the Orem room after the theory that I used. I created 2 of them, one at each of the main offices belonging to this home care agency. The room was secluded with relaxing music playing at a volume of 60 to 80 decibels. That's what the research showed me. The lavender oil was infused through the room. A sign-up sheet was placed outside of the room where the participants could sign up for a 20-minute session in the room each day that they worked. So that would give them up to 5 days a week to use the room. And like I said, I called it the Orem room. I got 31 frontline managers to be participants in the study. Of course, it was voluntary. They were all frontline managers for this home care agency in Pittsburgh, and they were all in an office setting. So I was hoping because of that and not being in acute care, they would be more likely to go use the room. I did do this over the course of the summer with the thought process of each one of these managers were granted 1 week off during the summer. So that took away the chance that possibly one person got time off and the other person didn't, to be sure that it was in fact the room that was causing any of the results that we would see. I did recognize that there would be possibly some barriers. Of course, turnover. We knew that that was a big problem in this particular area. I knew that it was possible over 12 weeks. I may lose some of my participants or have new ones come in. And of course, there would be possibility that the managers did not buy into the study and utilize the room. So we knew that possibly that could be barriers to this study. I used 2 surveys. One was the perceived stress scale, which is a 10-item tool. It asks the participant to rate an experience that they had within the previous month from 1 to 4. And the higher the score, the higher the rate of stress. The Maslach burnout inventory is a 16-item measurement tool that asks the participants to rate statements from 1 to 6, and that is anything they've ever felt at work. The higher the score, the higher the presence of burnout. Prior to the implementation of this room, they were given the 2 tools along with an explanation to write their self-given identification number at the top of the survey. They put it in the envelope. It was sealed. It was placed in a box outside of the Orem room. There was no way for me to see who was dropping those off. It happened again at the 6-week point, as well as the end of the study. And each one had a letter reminding them of how they created their identification number so that I would know that they would use the same one each time. Afterwards, I took all of the tools and the sign-up sheets and I matched up the identification on the sign-up sheets with the scoring I got on each one of those tools, and used the Wilcoxon non-parametric test because we did have such a small sample size. And we compared pre-intervention to midway, then midway to post, and then pre to post to determine if there was any difference among those. And we also looked at the rate of the usage of the room to see if that made any difference in the results. We knew that it was possible that some of them would not completely participate. And out of the 31 managers, 1 did no surveys, 16 did do all 3, 2 did just pre and post, 1 did just mid and post, 9 did just the pre, and 2 did just the post. So this results in about a 51% participation rate in completing all of the surveys. And of the participants who completed both the pre and post tests and used the room at least once, that would be 11. And then unfortunately, 7 of those managers did not use the room at all. We didn't find statistically significant results in almost all of them, except we found a statistically significant difference in the emotional exhaustion portion of the burnout inventory for the participants who used the room only once or more. So there were some limitations. The first one is I had multiple virtual sessions to explain the Orem room leading up to the moment. So depending on who attended which virtual session, they might have heard different questions at the end and therefore different information. The self-reported stress and burnout levels of the participants, of course, could have been affected by variables outside of the workplace setting. It's hard to talk about these studies without talking about COVID-19. It did happen during a pandemic, so there were outside factors like people's childcare was suddenly gone, or suddenly their spouse was out of work. So those were things, of course, happening outside that may have affected the stress or burnout rates. The lack of participation, of course, was a limitation. And afterwards, talking to everybody, hearing people talk when the study was over, a lot of people were verbalizing that they just felt like they didn't have enough time, which is contradictory to the fact that we see people run to Starbucks, go sit in the kitchen and talk, go do non-work activities. However, they were verbalizing that they felt there was no time for the room. It does lead, of course, to some discussion about what does this mean for the future of nursing. The strength of this study is the fact that it was very low cost upfront to get this up and running. It could be used at any office, anywhere for home care, hospice, any kind of agency that employs frontline managers like this. And like I said, because it wasn't acute care, because there wasn't direct patient care, it should be easier for somebody to go use the Orem room. So that, of course, is something we need to figure out why they didn't really. It's interesting because the improvement in the emotional exhaustion portion that we saw for somebody only using the room once or more, I think is interesting discussion, because if the evidence shows that you just had to go into the room once to see a difference in your emotional exhaustion, then why are you not using the room? And of course, creating and maintaining a healthy workplace is so important to prevent the intent to leave, to rebuild our national patient care workforce after the pandemic, and understand why nurses don't use the interventions that are in front of them when they are actively verbalizing the need for some kind of help. Recommendations for the future, research needs to be done into the feasibility and usefulness of the relaxation room. I think it warrants continued study, because we do see the evidence that these frontline managers are so integral in holding on to our nurses. In the future, I would use a pre-recorded message so we don't have different questions and therefore different information. But like I said, understanding why nurses do not reach out for the lifesaver per se when they are drowning. It is in front of them. They have the opportunity. So why they're not taking advantage, I think would be very interesting for us to look into, to understand how do we encourage people to take care of themselves? How do we change that culture to turn the tide and hold on to our nurses and protect our patients? Because of the shortage of nurses, a lot of nurses are expected to do more with less. They're expected to work more and sustain patient care. And then of course, our managers are expected to do more on top of that, as well as improving HCAHPS scores, recruiting and retaining, one-on-one with staff, nurse leader rounds, all of these things that evidence shows will hold on to our nurses. They're expected to do on top of taking care of patients when there's not enough staff. So changing the culture to ensure that our managers are not lost in the shuffle and they feel supported and they feel encouraged to prioritize self-care will then cascade down to our patient care staff, make them feel supported, teach them to take care of themselves, and I think help our patients in the long run. And that is it. If anyone has any questions or would like a list of the references, please feel free to reach out.
Lena, we don't have time for questions, but thank you very much for your presentation. Sorry to cut you short on time, but we are really tight.
Great job.
Good job, Lena. Good job. Did you read in the literature that nurses are the least people that will do self-care of all the people, and they're writing books about it now. I saw it I heard it on a TED Talk or saw it on somebody writing a book about healthcare professionals, how we take care of everyone, but we don't take care of ourselves. So that might be one thing. Okay, thanks. Very good. Do you guys have somebody in there you want to go? Or I will.
Oh, CJ's up next, and we're going to cut it at 20 minutes. I'm going to set my timer to go off.
CJ.
Okay. All right, very good. All right. It is my pleasure to introduce Cariann Johnson-Huber, CJ. In her 29 years of nursing, she has gained clinical experience in med-surg, critical care, peri-anesthesia. She has spent the last 10 years of experience as an informatics nurse manager with responsibilities including professional staff development, project management, budgeting, and information technology support. In addition, she's also in the past 15 years been an educator in staff education and adjunct faculty member at some universities around Pittsburgh. As a passionate systems leader, she provides mentorship to both graduate and undergraduate students in informatics. She has a master's degree from Waynesburg and is, of course, going to be graduating with her DNP at Carlow in May. She serves on various committees, medication safety, systems informatics, council, research, Q, and quality and compliance, and DNP student representative. Also, she's an active member of the American Nurses Informatics Association and Sigma Theta Tau. It's my pleasure to introduce CJ Huber.
Thank you very much.
You're welcome.
Very bright.
You look very bright, CJ.
Yeah.
I know.
A crazy background. Thank you again for that very.
Remember,
warm
she's an
welcome.
IT expert.
And of course, my IT always fails. I'm just saying. In the interest of time, I will keep my acknowledgement short. Thank you. A very heartfelt thanks to the Carlow University and all of the DNP faculty. A special thank you to Dr. Tennant being my chair and mentor. Dr. Bernie Doyle, who joined today, she was my clinical preceptor and another cheerleader along the way. Dr. Deborah Wolf, who is a champion in nursing informatics and my community expert. All of the surgical and leadership and staff at Hammett Hospital up in Erie, my site that graciously invited me into their home and team to allow me to do my project. And very especially to my work team and family who have helped me along the way with being my guinea pigs of this whole process. So let's start with my problem. Today's organizations are faced with a significant amount of cost to maintain
compliance with quality and regulatory reporting metrics when they have electronic medical records. In the year 2018, it was reported that over $39 billion was spent in organizations collectively to stay current with EMR or electronic medical record reporting. Every year, the number of discrete data points or the fields of areas of the patient's chart alone increase. As of 2020, there were over 700 discrete data elements, such as patient demographics, patient vital signs, implants, diagnoses, problems lists, smoking status. All of those elements are required to be reported to organizations such as the Centers for Medicare and Medicaid Services, AHRQ, multiple regulatory agencies, Joint Commission wants it, the Department of Health wants it, and now we have the 21st Century Cures Act requiring us to provide the same data elements to our patients. Why is this a problem? There's lots of barriers to keeping our electronic health records not only updated, but to make sure we provide education to our staff of those updates, in particular our OR staff. The reason there's barriers here is we have significant short staffing. We had short staffing before the pandemic, which has been exponentially catalyzed ever since. Pandemic changes, staff turnover rates, and the fact that we do not have structured training for our OR areas in relation to the electronic health record. We looked at what it costs our OR auditors and information specialists to review charts to make sure they're compliant for billing and auditing and reporting, and to send those charts back to the nurses to have them corrected. And essentially, based on the US Bureau of Labor Statistics, we spend about $1.4 million a year in making chart corrections and audits, which is a lot of money. So this is a big problem for our organization. So a little more on our background. Current state of our electronic medical record training, or the EMR training, occurs via peer-to-peer in our OR suites. For the orientation period, nurses are brought in. They're taught from their preceptor on how to chart in the record, and the majority of their training and education is focused on patient care. Updates to the record and the electronic healthcare system, electronic record system are made via email and staff meetings. We do not have dedicated EMR educators in the surgical space. We do have reference materials available, but they're hard to find and they're rarely updated. So the rationale for heading down this path to conduct this project was I wanted to make sure we're providing safe, quality care through innovation and technology. My passion is nursing informatics. Wanted a need to reduce the barriers of this IT education to our OR nurses. Wanted to improve cost savings to our organization. And what is determine the best practice on providing this education to our OR staff? Just because we've always followed one model doesn't mean we should continue to do so, because obviously it is not working. The specific aims of this project were to promote patient safety through a complete and accurate medical record at the point of care, so at the point of the surgical procedure. We want to improve reporting compliance to all of our regulatory agencies and quality repositories. We want to reduce costs, and most importantly, implement an evidence-based practice quality improvement project, not just follow the path of where we have always been before. We want to improve education. We want to improve our nurses' confidence. And we want to improve their satisfaction with the record. So I implemented a targeted on-demand video EMR education module specifically for the OR nurses. And this was aimed to align with our organizational mission and vision of providing patient care through innovation and technology. This led to my clinical question. Do targeted video on-demand electronic medical record education modules for OR nurses improve documentation practices to support data integrity for quality metric reporting and reduce daily chart corrections. So what did the literature show? First and foremost, a nice hefty theme that emerged of looking at all of the evidence that nurses really do value their electronic charts. They find that they're time saving and that there's good opportunities to provide some efficiencies there to really provide quality metric reporting. They like the ability to access data to improve patient care outcomes. And there is a healthy understanding in the nursing community from our new graduate all the way up to our advanced practice levels that all of this data that is available in our EMRs is how we can make advances both in nursing practice and medical practice, and that our patient outcomes in predicting how our patients are going to progress and do better is from all of this data we capture in the chart. So that led to looking at what are our best practices. The literature showed that targeted education, clinically relevant content, and time in the electronic system were the best practices for providing success in effective charting practices. What targeted education means is that, and clinically relevant, is that OR nurses want to learn about OR charting. They don't want to learn about ICU nurses charting. Doctors want to learn about doctor charting, not nursing charting. So it's important that we follow the best practices and provide relevant information to our staff. The ability to access education 24/7 at the needs of our staff is also a best practice noted in the literature. It met the expectations of our learners as opposed to the learners meeting expectations of the educators. And then most importantly was hands on the keyboard, as I like to call it, time in electronic medical record, in the train domains, in development domains, practicing on those keyboards, having it real time at their fingertips, not from a PowerPoint, not from an email, not from a lecture, but literally touching the keys so they have that confidence to be able to do what they need to do. So the theoretical model that I use for this aligns with information technology and informatics. It's a little different spin than some of the other nursing projects. In project management, and especially in information technology, we rely heavily on the system development lifecycle, and it follows very nicely with the EBQI model, the Iowa model, where you take your opportunity to improve on quality, you develop your question, you of course search your evidence, and then you create a pilot, you test it, and then you revise, and then you test it some more, and then you revise it some more, and then you implement it, and then you make it sustainable. That is how we handle a lot of things in informatics, and that's why this model was specifically chosen for my project. So a note about our ethical considerations. This project was approved by both the Carlow IRB and UPMC's Quality Research Council prior to beginning the project. All participants were voluntary. Everyone was anonymous. I specifically designed the education models so that they would be 100% de-identified. I would not know who watched the videos, and all of the reporting metrics I pulled had no patient identifiers and no nursing identifiers. This was obviously an evidence-based practice model and non-experimental design. So what did I do? I selected an area of the electronic health record in the surgical space that was of low volume, but high risk. And what that was our implant segment. And what an implant is in the OR is anything that we surgically place inside the body that is left there for 30 days or longer. And that's the FDA definition of a surgical implant. And I specifically narrowed that down even further to something we call an SN generic. SN stands for Surginet. That's the brand name of our EMR. And SN generic is an item that is not in our item master. So when you go to look for it in inventory, it doesn't exist. So you have to make it a generic item. And we have a very special methodology that you're supposed to use to document this. And there's not very often that this has to be done. So it is high risk, low volume, as every element has to be documented and reported. And it goes to all kinds of reporting agencies, including the patient. So what I did was create a targeted video on demand education module. It was a 5-minute video. I used a PowerPoint first to create all the screenshots. I recorded it using screen capture software, Camtasia. I added audio, animations, and illustrations so that the video was able to be utilized without any sound or with the sound. And then I packaged it all up and I put it on a secure YouTube channel. I added some QR coding so that the staff could access the module from their computer inside the OR or from their phone or an iPad or another PC. That way they could access the education right next to their computer while they were doing their documentation. I also created a post-satisfaction survey just for my own curiosity to see what the staff thought about this new method of providing them information. And all of these were provided with a QR code to help facilitate distribution and anonymity. So what data did I collect? Fortunately, because this data element, the implant field, the implant segment, along with this SM generic methodology, we have a discrete report available and has been available for over 10 years in our system. It's a validated report that all I had to do was run this report every day to see if there were any missing data elements. On the screen here, you can see a snippet of the report. And the things that are supposed to be captured to be compliant are things like the entire description of the item, the manufacturer, the manufacturer number, and unique identifiers. The ones located here in red obviously are missing and they thought were non-compliant documentation. I collected the data for 28 days prior, and I was intended to collect it for 28 days post. We ended up collecting for 29 days because there were 2 full days of no implants at all, and we needed to get enough sample size to be comparable pre and post intervention. So what did my data show? I'm very pleased to show that when we did the first Z-score, that the proportion of complete versus incomplete SM generic documentation segments was highly statistically significant. So prior to the education module, there was very poor compliance of documenting all of the required elements. And then after the training video was viewed, compliance skyrocketed and staff were actually filling out all of the elements that were needed. We then further took that and did 2 independent t-tests to ensure that we had congruency with our Z-score, and it showed the exact same thing, that pre-intervention to post-intervention, we had highly statistically significant results. So in a simple percentage increase calculation, it showed we went from 16% compliance to 80% compliance, or an increase by 385%, which made my unit directors very, very happy, as well as my OR auditors. So there was a very positive correlation between the video training and our education documentation compliance. The staff it was highly statistically significant with p-values of less than 0.0001. And this evidence supports that the intervention was an effective method of getting this information to the frontline staff. Additional data I looked at, again, was that staff satisfaction of what they thought about this training methodology. And then I also asked the OR auditor and IS specialist at the facility to keep track of their time and how much time did this save? Did we reduce anything for them? So some of my key findings, out of 116 SM generic implants, 95 had all elements completed at the point of care and did not require chart corrections. And that was every single field filled out on that implant segment. And surprisingly, the ones that did fall out, they were only missing maybe 1 data element, as opposed to prior where all of the data elements were missing. So even if they weren't 100% compliant, there was still marked improvement in documentation. The OR auditor and IS specialists reported that their charting activities were cut in half. And it saved them 10 to 15 hours per week, which is a significant impact in efficiency and their workflow, not to mention that translates to the nurses having to go back in and correct their charting. So that's almost half of a person right there, just in one segment that we were able to improve. We were able to save resources by not providing hands-on education. A physical person did not have to go to the rooms. They didn't have to stand with the nurses. We didn't have to teach them directly. It was all delivered electronically, and the message was consistent. Every person watching the video heard the exact same training. The staff satisfaction survey came back with highly satisfied feedback. So the nurses who did complete the survey were very happy with the new methodology. A few limitations. There was short staffing. We had a lot of turnover and losing staff. So we didn't have as much participation as we would have liked. There was, because of the de-identification of the participants, I was not able to pull out anyone who was an expert in documentation. So if they were a clinical super user, a clinician, or an IS specialist who was very comfortable with documentation, they were in both the pre and post sample without knowing if they were, an expert. We had some variance in our OR schedules, especially on the planned days of data collection. We had to be careful to make sure we had good compliance between pre and post, that we had a similar number of implants. And then we are constantly adding items to the item master to ensure that we're reducing how many we have to add. So usefulness and so what for nursing, what does this mean? On-demand availability of point-of-care messaging for education. That's improved staff documentation. This type of education module aligns with the 2021 AACM Essentials to use information technology to improve communication across systems. It's definitely sustainable, requires no human resources or staff impact. It's updatable, electronic, and repeatable, and shareable on multiple devices. For further research, we'd like to do the study longer, maybe look at a better study for staff satisfaction and look at different segments. Next steps, this module I'm pleased to announce has gone system-wide and is already in place. And I have been tasked with creating one for some of our other low volume, high risk segments, as well as an entire orientation program. And I'm pleased to announce that the Journal of Informatics of Nursing has expressed interest in publishing my findings. So thank you for your kind attention. And please email me with any questions, and my references are available.
Awesome, CJ, good job. You have exactly 40 seconds for questions. 34 seconds.
Anybody? Yeah, she's gonna, her journal, her research got accepted with some, with revisions, of course, for journal publication. In nursing informatics, is that what it is, CJ?
Yes.
Yeah, so that's very exciting. Congratulations. Good work.
Hey, CJ, good job. And if Nikki's next, I'll read her bio sketch. Is that
Okay.
who's next?
Okay.
Is that who you have on
Yes.
your schedule? Okay.
Yeah, no, yeah, Nicole.
Okay, Nikki and then Corie. Corie is last, right?
Yeah, Nicole, you ready, hon?
I am ready.
Okay.
Somebody talking.
Kate, yes, I sent Kate a message.
Okay.
Oh, Kathleen is not.
Okay,
It's not right.
Sorry.
Okay.
Thank you, Maria.
Okay, the bio sketch for Nikki is Nicole Michelle Wild is a registered nurse for nearly 10 years. She earned her MSN from the University of Pittsburgh with a focus in nursing administration in 2015. Her BSN from Carlow University with a minor in counseling in 2012, and completed her AA degree with a focus in psychology from Community College of Allegheny County in 2011. Nicole has held several positions in nursing at and away from the bedside, including critical care, perioperative nursing, where she is certified telephonic case management, and clinical transformation consultant, which is a Medicare product for the third largest integrated health delivery system in the nation. She most recently worked as a clinical instructor specializing in adult health, critical care, and laboratory instructor for 3 local colleges within Western Pennsylvania. Nicole currently works full-time at Highmark Health as an experienced research manager, gathering and performing qualitative analysis of pre-selected and utilized virtual health outcomes. This role includes a venture with Verily, formerly known as Google Life Sciences, to support their Living Health model. And Nicole enjoys philanthropic work by serving in her community and profession. She is an active subcommittee community outreach member and recently appointed education chair for the Greater Pittsburgh chapter of the Association of Nursing Professional Development. As a subcommittee community outreach member, she successfully fundraised for local donations to support the annual conference for the GPC AMPD sponsored organization, the Angels of Allegheny. This donation was aimed to obtain additional supplies for their outreach endeavors of memorializing nurses that have passed on. Nicole enjoys cooking, traveling to Florida, a true national park enthusiast, and spending time with her family, little niece, and friends. She currently resides in Pittsburgh, Pennsylvania, and she shall begin her DNP presentation. Thanks, Nicole. Good luck.
Thank you, Dr. Engel, for that introduction. My project is the impact of peer feedback using video recording device in simulation on clinical competence and knowledge, a quality improvement pilot study. Some acknowledgements. I would like to first brief you with those. For the past 2 years of this journey, I would like to thank God, first and foremost, Dr. Renee Engel, my faculty chair, Dr. Marsha Cook, my community expert, my preceptors, Dr. Sarah Angelilli and Dr. Danielle Curran, the Cecil Lab and staff at Carlow University, the nursing students and family and friends for your encouragement and support, some of which are on the call this evening. And these are pictures of my family. So the problem description: among undergraduate nursing students in simulation, self-confidence, competence, and self-efficacy impact simulation performance. Thus, it is necessary to explore strategies to improve clinical competence, self-confidence, and knowledge is essential. Currently, undergraduate nursing students participate in simulation experiences in a standardized format. Typically, faculty assign students to pre-work related to the outcomes expected by simulation. Then on the day of simulation, faculty conducts a pre-briefing, the students participate in the simulation, and then the group engages in a debriefing process related to performance and outcomes of the simulation. The local problem. Currently, faculty within a small faith-based university conduct pre-briefing and debriefing without peer feedback or smartphone technology video recording for each simulation experience. This study evaluated the incorporation of peer feedback with a mastery of a skill and incorporation of a video recording device. My research question posed was the following: do undergraduate nursing students who receive peer feedback using a video recording device in preparation for simulation attain higher self-reported clinical competence, self-confidence, and knowledge post-skill competency testing using the clinical competence questionnaire? My definitions of terms include clinical competence, self-confidence, boot camp, junior level curriculum, senior level curriculum, pre-briefing, simulation, and debriefing. Clinical competence ensures that the student nurse ability to demonstrate safe and effective skills once previously learned. Self-confidence is a feeling or belief about abilities to perform, organize, and execute a task. A nursing student's self-confidence is an element for growth and development. Barrage et al. Defined boot camp and education as an intensive course delivered at the start of a new clinical role designed to provide a foundation to a curriculum through practical training. This definition will be important to recall when discussing the series of events leading up to implementation. Junior level curriculum. The junior level curriculum attended in the small faith-based university is defined as an individual who has completed 63 credit hours towards the 120 credit hour requirement for obtaining a bachelor's degree in nursing and have completed hours within the simulation lab related to vital signs, physical assessment, and medication calculations. Senior level curriculum is an individual who has completed 93 credit hours towards the 120 credit hours and have completed hours within the simulation lab related to all areas of a junior student and IV therapy. Pre-briefing is a specific objective of simulation and is presented by faculty, such as the nursing process and receipt of guidelines based on the scenario shown. Pre-briefing may also include discussion of the scenario of the students, answering questions, conducting an environmental orientation, and role creation. According to Cambridge University Press Dictionary, simulation is defined as the model of a set of problems or events that can be used to teach someone how to do something. Following simulation is debriefing, which is a process that transpires immediately after the simulation. And during this phase, a survey may also be provided for the participant to complete regarding the experience. This strategy allows the participant an opportunity for self-reflection, as well as feedback creatively and positively through a structured approach of discussion, and a chance to correct potentially undesirable nursing performances within simulation. Peer feedback is a communication process through which learners enter into dialogues related to performance and standards. Video recording device, or also known as the VRD, may include but is not limited to a smartphone or tablet with camera capability, laptop with camera capability, or the OWL recording device, which is located in the simulation lab and accessible for all students. Available knowledge includes confidence in simulation, peer feedback, competence in simulation, and video recording. Confidence and simulation. Simulation-based learning within a nursing program enhances the learning experience and also improves knowledge through a controlled environment. Simulation is utilized for skill attainment related to competencies expected upon graduation. These include physical assessment, indwelling, catheter insertion, and wound care. Simulation allows students to practice, prepare for, and reflect on their learned skills before performing them in a clinical situation. The confidence gained in simulation is well documented. Yet anxiety leading up to the simulation during pre-work and pre-briefing impacts self-confidence and performance of skills. Self-confidence is relevant to this quality improvement pilot study on simulation-based skills learning because of the impact on overall performance. And those individuals with higher level of self-confidence were found in the literature to have a better performance outcome. Incorporating peer-to-peer interprofessional feedback helps optimize teamwork and professional communication. In the clinical environment, peer feedback constantly occurs during shift-to-shift handoff reports and between various healthcare disciplines. Effective communication is necessary to provide the highest quality of care for a patient to receive. Timely and direct face-to-face feedback that is objective, specific, and grounded in behavioral observation has been proven to be most effective. Studies have demonstrated that incorporating peer feedback early into the curriculum and active peer feedback can produce positive outcomes, such as improvement in confidence and competence. Peer-to-peer feedback in education can provide positive and active support to the learner and the potential to improve learning outcomes. These findings are essential to this quality improvement study since peer feedback is an integral part of the intervention. Competence in simulation. Providing additional practice time in the lab to foster mastery of the skill, accompanied by immediate feedback, is recommended to enhance students' competence. Voluntary workshops is an example of an opportunity to practice without the rigor of testing. Finally, the research has demonstrated that additional opportunities within a controlled environment of simulation and skills laboratory can enhance clinical practice skills and competence. This development requires students to spend adequate time within the lab, receive immediate feedback on their techniques, and reflect on their experiences. And lastly, in the available knowledge is the video-based recording in education. Nearly 97% of Americans own a cell phone. 85% of those devices are smartphones with a video recording capability. Therefore, incorporation of video recording should be met with feasibility regarding this type of ownership. Current research has demonstrated the positive influence on learning and skill development through this innovative teaching strategy utilized in this pilot study. A recent study conducted by Johansson and Yarba provided the incorporation of VBR with peer feedback of a psychomotor skill of indwelling urinary catheter validation. The researchers studied a total of 81 students completing their second semester of their baccalaureate program in the 2 4-hour lab skill sessions. The evaluation process was multidimensional, including self-evaluation, peer feedback, and student perception using open-ended and Likert scale type questions. This study found that 96% of students agreed or strongly agreed that these skills could perform safely in this manner. Additionally, 78% agreed or strongly agreed that smartphone utilization was very beneficial to learning the craft. This happened to be the component of inspiration for my doctoral project and elevated the research findings as the framework for my study. The theory that I chose was Albert Bandura's theory of social learning. He proposed that learning takes place from social experiences and examines the belief that human beings actively process information and ponder about relationships between consequences resulting from their behavior. An example of this type of social experience takes place within the simulation skills laboratory. The VRD component allowed the participant to review their behavior and appropriate consequences of their actions independently or through peer feedback because of the focus on how mental factors are directly involved in education. Throughout this project, examining the use of VRD in clinical simulation, the participants actively process information by performing a defined learned skill in a social situation. My specific aim for this pilot study examined the effects of incorporating peer feedback using VRD during nursing simulation to ascertain self-reported perceptions of clinical competence, self-confidence, and knowledge post-skill completion in undergraduate nursing students. For my context, the location of this study was a state-of-the-art simulation lab at a small faith-based university in Western Pennsylvania. My sample and eligibility, a convenient sample of undergraduate junior level nursing students were recruited and 28% participated. Eligibility for inclusion included the junior level nursing students in the traditional undergraduate baccalaureate program. Senior levels students were not included in the original study group, but were eligible for post-hoc examination. IRB approval was obtained from Carlow University following appropriate ethical considerations and protection of human subjects. Students were invited to participate via faculty upon completion of scheduled boot camp days and through postings on the simulation course site. Consent was obtained from the participants and were informed of all potential risks, including mental stress, risk of exposure, and embarrassment. The intervention was a pre-test, post-test survey, and each participant received a self-sealing envelope upon the arrival to the workshop and on the day of skill sign-off if they participated in the workshop. The intervention took place in 3 distinct phases: the boot camp, the workshop, and the skill sign-off. The boot camp was an 8-hour session where they reviewed skills from sophomore level and are introduced to the new skill of IV therapy. The workshops consisted of 3 familiar components: pre-briefing, skills-based simulation, and debriefing. Approximately 15 one-hour in-person workshops were offered during 2 weeks with a maximum participation in each session of 9 students. The skills sign-off, the junior level students were required to schedule this appointment regardless of attending a workshop, where they did demonstrate a level of mastery of the IV therapy skills presented in boot camp. Upon completion of the workshop, the participants were offered a post-test for completion. This slide here reviews the workshop process, which took place in those 3 phases: pre-briefing, simulation or skill, and debriefing, which the students again were familiar with the process since the workshops did mimic a simulation day. For the pre-briefing, this was a 15-minute step where the pre-survey was administered. The review process of the newly learned skill in boot camp was briefed and completed as a group. The students divided themselves into pairs, 1 pair at each station, and brought their video recording device with them. The stations were equipped with the supplies needed to conduct IV therapy skills. The simulation skill. The participants were instructed to perform the skills learned and provide constructive feedback during and after demonstration with one another. For ease of obtaining their own video and with permission, the recorder used the performer of the skills video recording device so that videos did not need to be sent. Each student was given approximately 15 minutes prior to switching roles to complete the skills. The total time of the simulation was 30 minutes. Debriefing. The entire group came back together to debrief, where a random video was chosen to view with constructive critique. This part lasted 15 minutes. Prior to exiting, the researcher encouraged participants to schedule the required skills sign-off for appointment. This was also where a post-test was provided to complete. The total workshop time, as noted here, was 60 minutes. This slide gives an overview of the skills related to the IV therapy that were reviewed in boot camp, practiced during the workshop, and as a skills sign-off. The questionnaire chosen was the Clinical Competence Questionnaire. This was a 47 5-point Likert scale that measures the continuum of the nursing program in the early period of the traditional nursing career. Many of these questions were not applicable to the study or population. Therefore, I, as the researcher, narrowed the questionnaire down to 7. They were evaluated and ranked on level of significance by 3 faculty members within the undergraduate nursing program. These 7 items were sent to the author to request a review, and permission was obtained to condense. This slide here shows the 7 questions that were asked of the participants. Please also note the demographic questions, including age, sex, and employment status in healthcare and non-healthcare roles, were also used and asked as a post hoc analysis. The analysis of the results took the mean total scores of the pre-test, post-test surveys and were analyzed using a Wilcoxon sign rank test, comparing the pre-scores and post scores, in addition to examining the post ad hoc data for 5 data performances, one of which will be discussed in further detail. Table 1 includes both groups of participants for a total of 47 participants. Results demonstrated a positive correlation between participation in peer feedback and video recording and skills-based competency of undergraduate nursing students in all 7 areas of measurement. Table 2 is data analysis related to employment status of the junior and senior level participants. Please note question 5. There is statistically significant difference in the change scores comparing students' employment and healthcare. Therefore, this suggests that employment status in healthcare has significant benefit on competence and knowledge while attending nursing school. Table 3 depicts the junior class analysis of the CCQ. IV therapy questions are specific as number 4, 5, and 6. These demonstrated statistically significant differences in the post and pre scores, suggesting the peer feedback and video recording device while practicing simulation of skills improves self-confidence, competence, and knowledge. So to summarize this study demonstrated peer feedback and the use of VRD effectively impacted perceived self-confidence and competence. The simple step of adding readily available technology such as smartphone with video recording and peer feedback can improve perceived self-confidence and clinical competence in nursing simulation. My strengths are listed here as well. The researcher myself was familiar with the protocols related to simulation, familiar with the students and alumni of the university, and these students were really digital natives and efficiently utilized VRD. My limitations are listed here: small sample size, large commuter population, influence of peers, time constraints in the workshops, as well as embarrassment or uncomfortable feeling using VRD. Sustainability would include incorporating the workshops in the graduate assistant pre-scheduled hours. Workshops could be held within all levels of the program, and an opportunity for the grad assistant to be creative and tailored to the needs of the nursing cohort. Future implications may include a QR survey for evaluation, offering additional sessions, and increasing the number of students in the sessions to 12 per workshop to eliminate the amount of workshops needed. These are my references. Are there any questions? And I leave you with 1 minute left with 2 quotes, one of which is Florence Nightingale, the founder of modern nursing, and the other is Dolly Parton, country music superstar. Thank you very much for your time and your attention.
Hey, good job, Nicole. Unfortunately, we don't have time for Q&A.
That's okay. You can email me if you have questions.
Yeah, or email her, or we might have Q&A on our DNP presentation day. All right, we have one more. Corie Scanlon. Was anybody introducing you, honey?
I think Dr. Engel has my bio sketch.
Okay, wait, you know what? I think I had to turn their voice off. Hold on 1 sec. Hold on a second, Renee. Okay. Shoot.
Can you hear
Okay.
me now?
Yes, yes.
Awesome. Okay. Hi, Corie. I would like to read Corie's bio sketch. Corie Scanlon is currently a DNP candidate at Carlow University. She received her bachelor's degree in 2012 at Indiana University of Pennsylvania and her master's degree in 2017 at Carlow University. Corie is a nurse practitioner. She was a professional staff nurse at Pasadena Hospital and spent time as a travel nurse on the West Coast. Corie currently works as an NP with Matrix Medical Network, previously working as a chronic care practitioner in the home setting. My mouth is tired. Her interests focus on primary and palliative care. In addition, Corie embraces an innate desire for working in a leadership position where she can support other NPs in providing quality care and practicing within their full scope of practice. Ms. Scanlon resides in Pittsburgh, Pennsylvania with her fiance, Jim, and is very soon looking forward to planning their wedding as soon as she passes this DNP program.
That's right. That's right.
Oh, nice. Okay, go ahead.
Okay, here I go. So the title of my project is Identifying the Attitudes, Beliefs, Self-Efficacy Barriers, and Practice Behaviors of Nurse Practitioners Providing Smoking Cessation Counseling to Patients. Quick acknowledgement to Dr. Renee Engel, who has been my chairperson and helped me so much, Dr. Beth Zamboni, who helped me with all the stat work for this project, and then Dr. Jennifer Kuna, who was my mentor and community expert, and then all of the university, Carlow University DNP faculty. Thank you so much for everything you've done. Okay, so what's the problem that my project addresses? Tobacco use is the leading cause of preventable death and costs the United States billions of dollars every single year. So smoking cessation counseling is widely recommended as a way to reduce tobacco consumption amongst the public. But when we survey adult smokers, only about 60% of them report that they're being counseled by their providers. So we're missing a large portion of them. To improve cessation rates, it's really important to understand the current practices. And then this project's going to focus on nurse practitioners. I'm going to call them NPs a lot throughout this presentation because of their essential role in behavioral change and patient counseling, which I will go more into in just a minute here. And then important to note, few studies have explored NPs and their relationship to smoking counseling. My clinical question and specific aim is to explore what the attitudes, beliefs, self-efficacy barriers, and practices of NPs providing smoking cessation counseling to patients. Okay, so first, what's the NP role? So what is a nurse practitioner? Nurse practitioners are nurses with advanced degrees at the master's or doctorate level. They often function similarly to that of a physician. They have their own patient panel a lot of the time. They can diagnose and treat acute and chronic conditions. They can order labs, test, interpret results, prescribe medications. And then they do a lot of lifestyle counseling, like smoking cessation counseling. They're really skilled at communication, active listening, things like that. They have a really unique background and a lot of times have a whole patient approach to care. So they are really involved in those lifestyle and behavioral changes, which all helps them play an integral role in helping patients to quit smoking. So next is, why is tobacco so hard to quit? So I think what's important for people to know is nicotine's a chemical that's naturally found in the tobacco plant. So it's in every tobacco product. What nicotine does to our bodies is it stimulates the release of dopamine, and dopamine makes us feel good. So it makes us have increased alertness, decreased anxiety. Some people feel euphoric from the dopamine and things like that, but it's short term. So as that wears off, the user or the smoker wants more. And so over time, they become dependent on nicotine. And when that user or smoker, in this case, tries to quit, they get withdrawal effects. So those withdrawal effects are things like anxiety, irritability, trouble sleeping, just really bad cravings. And they're worse in the beginning, but most people don't make it past that phase. And so they pick the cigarettes back up and they relapse. Studies cite all sorts of numbers, but some of them say it takes up to 30 quit attempts for some people to stop. And so also important to know is there's about 7,000 chemicals that are added to cigarettes. 70 of them are known carcinogens, so they can cause cancer. They're added by cigarette manufacturers to make cigarettes more palatable, so they taste better to us. They're more enjoyable, and also it helps the nicotine get delivered to our brain in a more effective way, so it makes them more addictive. So the complexities in the addictive nature of cigarettes are why providers need to be skilled in cessation counseling. We need them to support patients, to educate patients, to prescribe medications when appropriate. All of that is really important for patients to be successful in quitting. Okay, so what are our treatment plan options? What we know is tobacco dependence is a chronic condition. A lot of times it takes repeated interventions. The Treating Tobacco Use and Dependence Clinical Practice Guidelines state that counseling and medications can be effective independently, but most users benefit most when they're used together. So counseling can look a lot of ways. It can look like individual counseling, group counseling over the telephone, something like that. Studies do support longer term counseling, like weeks to months versus days. And then medications, you've probably heard of things like Chantix, Wellbutrin, and then those nicotine replacement therapies that come in patches, lozenges, gums, things like that. And then importantly, what are the guidelines? What are providers supposed to know to practice? What do they follow? Well, that same Treating Tobacco Use and Dependence Clinical Practice Guideline, that was created by the U.S. Department of Health and Human Services. That gives the most up-to-date and complete guideline. It's called the 5 A's. So the 5 A's go: ask about use, advise to quit, assess somebody's willingness to quit, assist through counseling, meds, referrals, and then arrange a follow-up. There are different models, but pretty much all of them kind of reference those 5 A's. So that's the one that most providers use, and that's the one that I most looked at for this project. I did a literature review. It's important to say there's not a lot of literature on nurse practitioners, especially when you look at smoking cessation. So I had to use a literature review that included physicians, nurses, mid-level providers, and sometimes pharmacists. So when I looked at self-efficacy, it's important because poor self-efficacy may be a barrier to counseling. So there were some themes in the lit review. Majority of nurses and physicians report little to no training on cessation counseling. Nurses report lacking confidence in their skills, and they have conflicting opinions about their ability to influence a patient's approach to their health, so to influence their behaviors. Some providers attribute their low self-efficacy to a lack of training. And then a higher self-efficacy scores were associated with a higher intention to provide smoking counseling. Attitudes and beliefs are really important because the better the attitude, the more likely someone is to do something, and vice versa. Poor attitude, less likely to do something. Looking at this, the studies had really conflicting outcomes. So many providers had unfavorable attitudes. They were quoting things like, it's burdensome to my patients, it's a waste of time, it's not the duty of the physician. But then other studies found that providers have positive attitudes. It did find that unfavorable attitudes were highly correlated with inadequate knowledge on the topic. So there's that training piece again. And then there was a correlation between having a positive attitude and having high self-efficacy. Practices are important. You know, we're in this really interesting situation right now, especially in the outpatient setting where we have 15 to 20 minutes with a patient. We have all these competing health concerns. So it's important to see that, like, maybe a provider knows the guidelines, but how are they translating into patient encounters? This also had really conflicting outcomes. It's interesting. So this first Sipos et al. Study from 2018, that was a chart review. So it had a really big population of adult smokers in a general practice setting. And the study just reviewed their charts, and it found that only about 30% of them were being provided smoking support. So pretty low. These next two studies were survey reports of providers. So they were reporting their own practices. This first one, almost 87% of nurses and physicians report counseling their patients. But this second one, only about 50%. So there's not really consistency in these studies. Then I looked at barriers. So identifying barriers will enable organizations to make changes and develop action plans to eliminate these barriers and mitigate their effects. Top barriers that I found were lack of training, lack of resources. That kind of goes into this next one, which is a lack of structural support, which is limited programs, time, staff, and finances. So what's the rationale? Well, NPs are expected to be a cost-effective solution for this physician shortage that we're right in the middle of. Right now, they're about 1/5 of the primary care workforce, but as our population keeps increasing and we keep having less and less providers, they're expected to kind of swoop in and be more than 1/5 of the primary care staff. So they have an important role in health promotion and an opportunity to significantly influence national tobacco objectives. So it's really important to know how their smoking counseling habits are. Understanding the attitudes, beliefs, self-efficacy barriers, and practices of NPs regarding this type of care will identify if needs for education exist and what barriers to address. And then it's also plausible to say that by empowering NPs to provide more robust smoking cessation counseling, we can positively impact cessation rates, our population's health, and the associated healthcare costs. I'm just going to kind of touch on this briefly. My theoretical framework was Albert Bandura's social cognitive theory. Basically, what people think, believe, and feel affects how they behave. So in a nutshell, if somebody feels like they can do something or feels like they're capable, they're more likely to attempt that over and over. And vice versa, if they feel like they do not have the skills and do not feel competent in something, they're less likely to do that thing. So applying this to smoking cessation, like, how does this apply to NPs? How do they feel about their skills? How are their attitudes, and how can we affect them so that we empower them to do these practices with confidence? So the context for this study, we're in the methods section now, was that a convenient sample of NPs from one single healthcare organization that provides wellness assessments in the risk adjustment sector throughout multiple states in the US participated in a descriptive survey study. No additional interventions were performed. This organization employed a lot of NPs, about 2,000 NPs worked for them at a time. So all of them were invited. They all worked for the organization and they had to meet the criteria of providing direct patient care. They couldn't be in a management role or anything like that at the time of the survey. So this organization already sent out a weekly email from the education department. So this was added into that email 3 times over 6 weeks. There was a brief description of the survey study and then a link. So if somebody clicked on the link, it went to an informed consent page that kind of explained what was going on and told them everything that they would need to know. And then it said, you know, do you give consent, yes or no? If they clicked yes, it took them to 2 elimination questions. So that made sure that they were an NP providing care. The other one asked that they hadn't completed the survey already. As long as they answered those both in a way that was positive, so yes and yes, they were able to move on. And then they would start the survey. So for measures, I used the Smoking Knowledge, Attitudes, and Practice tool, the SCAP tool. I did modify it with permission from the original author. It was already assessed for validity and reliability. The study used Likert scales, and you can see them here. They change based on what area I was assessing, but that was very clear on every question when somebody was filling it out, you know, what they were choosing from. SurveyMonkey platform was used to average responses. So it had a function where it could just average the responses and use a weighted score, and that weighted score became a mean. And so that mean could be used to assess the level of agreeance or importance for each question among the population as a whole. I also decided to add some demographic components to this. This included age, number of years in practice, first degree earned as a nurse, highest level of degree in nursing, and did they ever receive formal education or training on providing smoking cessation counseling. I did this because I wanted to see if demographics changed their responses to the SCAP tool or not. With that, I did a post hoc analysis. So I couldn't use everything. It was just too much for this project. So I chose the things that seemed most important. So 2 demographic elements, which was years in practice as an NP, and I divided that into less than 5 years or 5 years or more. And then yes or no to status of having received formal training on smoking counseling. And then I chose 4 questions of interest. So 2 from the barriers section, lack of training and lack of impact on patients. 1 from attitudes, counseling by a clinician helps motivate them to quit. And then 1 from the self-efficacy, which was I have the required skills to help my patients stop smoking. And then Dr. Zamboni helped me with doing the chi-square and Cochrane arbitrage test for trend to see if those 2 were associated at all. Ethical considerations, this project was approved by the Carlow IRB and the Clinical Governance Committee of the participating organization. Informed consent was obtained from everybody, and everybody was kept anonymous. Participation was voluntary, and they had the option to withdraw at any time with no penalty. All the data was collected securely on SurveyMonkey. No IP addresses recorded. Data was stored in a password protected device, secure location, and was only used for this project. Okay, so to the good stuff, the results. Participants, there were 146 participants, about a 7% response rate. The vast majority were 35 years or older, and over 50% had 10 or more years of experience as an NP. So they were a pretty experienced bunch. Notably, less than half of them, 38% of them, report ever having received formal education or training on smoking cessation counseling. So this first area I'm going to look at is the attitudes. And then the question says, is smoking cessation is an important part of my job? So we want to look right here at this orange and blue. That's agree and strongly agree. That's what we hope the providers are saying. And you can see it takes up almost all the chart. 88% of them agree. So that's good. They think it's important. These are the other attitudes sections. So clinicians should advise patients to quit, even if it's not the reason for the appointment. Over 93% of them, this blue and yellow, agreed with that. So that's great as well. But we go to here, only 55% of them felt that clinicians should make appointments specifically for discussing quitting. So to me, that says, okay, they think it's important, but not as important as some other health concerns. So now we're on to self-efficacy. This first one here, I have the required skills to help my patients stop smoking. So if you look at this orange and the blue, it looks like a lot of it, right? But it's 72%, which sounds big, but when you think about that, that's over 1 in 4 providers don't feel like they have the skills. So that's a big chunk of providers that we could really work on. And then this one is, I know where to refer my patients for help. So again, these blue and orange are the good ones. Yellow and down is neutral. So we look here, only 67.5% knew where to even tell people to go. So that's somewhere we can really focus on. These two in the middle are about patients. My patients are concerned about smoking, and my patients who smoke want to quit. They're about 50-50 for both. I know it's kind of hard to see with the colors, but it's about 50-50 for these. So that's saying like they don't have that much confidence that patients are even wanting this kind of counseling. About half of them aren't even sure. For practices, we want to look here first. This is ask your patients whether they smoke. Look at this. It's pretty much everyone. It's over 99% of people say that they're doing this regularly. And then if we look here for practices, advising to stop smoking completely is the most consistent practice here in comparison to these other ones. Barriers, the top were lack of patient interest, lack of patient compliance, and other health problems requiring attention. Interestingly enough, smoking cessation guideline complexity and lack of training scored low, but it's important to know that there was a statistically significant association and trend between formal training status and identifying lack of training as a barrier. So although the training is rated low, having had training does make it even lower. It does affect it in a good way. Okay, so what can we think about that, all those results? We could say NPs value smoking counseling. They feel a sense of duty to advise patients to quit. The top barriers are patient centers. So lack of patient interest, patients don't comply. That means NPs feel they appreciate the counseling more than maybe their patients do a lot of the time. NPs report high compliance with assessing smoking status and advising to quit, but that's in conflict with some of those earlier reports that only 60% of patients report being counseled. So maybe there's a difference in the perception of our providers and our patients that we need to look into further. Really important, less than half these providers had training. So where are they getting this? And that though lack of training was a low barrier, this study and others do support that it increases self-efficacy, which is important. Limitations of this study, the job responsibilities of these participants don't include ongoing care. So they don't write prescriptions or manage these patients regularly. So that could impact how they responded. I did not do a good job of defining what having had training or education on smoking counseling was. And so there might not have been a uniform understanding for that question. I wish I would have done a better job there. Next, the SCAP tool, it was supposed to be used in the drug treatment setting. So I had to take a whole knowledge section out, and I had to take some questions out because they weren't relevant. Though I will say, I think the tool did a really good job looking at what I wanted to, but maybe there's a better tool for the general practice setting. And last, we always worry about self-reporting. Like, did the respondents have the introspection to be able to look at themselves accurately? Were they responding based on what they thought that they should say rather than what was actually accurate? That's always kind of a concern with self-reported studies. And last slide here is about future practice recommendations. So I think we need to improve provider self-efficacy through training. It's important and appropriate at both the academic and professional levels. So maybe that's incorporating into our lectures or having onboarding modules, things like that. We want our organizational infrastructures to support this kind of counseling. So having pamphlets for patients, making sure providers know where to refer people to, making sure they know how to bill for this, and encouraging providers to do this consistently. Next is there should be more studies that explore providers' experiences with smoking counseling in the primary care setting. I didn't go into it too much, but my lit review had to use all of these like specialty settings, but we know that this usually happens in the primary care setting. There's just not enough up-to-date literature, so more should explore it there in the correct setting. Not that it's correct, but the most relevant setting. And last, some research on brief educational interventions for providers. So what are some maybe modules that we could give them, or some quick lectures that we could use in class and things like that, that would be effective on teaching people and providers how to give great care as far as quitting smoking. And these are my references, and that concludes my presentation. Thank you very much.
Yay. Good job, Corie. I liked it.
Thank you
You're
very
a good
much.
speaker too. You're a good
Thank you.
speaker. I would say some of your slides, the print is a little small though, honey.
Okay.
Okay. I mean, I'm just putting it out there.
Make it bigger. Okay.
Yeah, or put less on one or something. Increase the
Okay.
font. I mean, I know I can't see. I got like these bifocals and all things going on, but you know, just that my 2 cents. Okay, Well, listen, Dr. Engel,
We're
anything else you
done.
want to say? We are on a time limit, unfortunately. We have surpassed our time, but I think it was extremely worthwhile. I was actually very impressed by all of them. I knew some of you, but some were new to me. So really good work, everybody. I look forward to seeing you at a graduation and maybe honors convocation and doing your presentations after honors convocation. Dr. Engel, what would you like to say?
That's all. Thanks for hosting and moderating, Dr. Tennant, and thanks to everybody who attended this evening. Y'all did a great job, and we'll see you very soon. And there goes the timer. Okay, we're done. Good night, everybody. Safe driving to you.
Thanks, everybody.
Thank you. Bye.
Thank you.
Okay, see you soon.
Good night.
Thanks, Maria, to our host, Maria.
You're
in
very
Peru.
welcome.
Maria.
A pleasure. Bye-bye.
Thank you very much for the extension.
My pleasure.